Okay. Hello, good morning, everyone. So I'm presenting on like a sick febrile child. So it's the IP1 curriculum. So let us start. So my content will be like curriculum, like new curriculum versus old curriculum, and the definition of fever, causes of fever, disease, and etiology, and basically like history taking, examination, and what is like a traffic light system in like febrile children, a different strategy for management of febrile child, pediatric sepsis flowchart according to our Doncaster and Bachelor Hospital Trust guidelines, and what is like pediatric sepsis 6 and the adult sepsis 6, and my some references and take home messages. So first we'll go through, this is the like new curriculum. So basically new curriculum is a like broad heading. It contain like fever, IP1, and it also include like some sepsis. And we basically talk regarding like pyrexia of unknown origin and some Kawasaki diseases. So this heading contain like us because it's a sick febrile child. So it contain like broad things. So I could not like cover within like 45 minutes all the things. So I'll briefly discuss regarding the sick febrile child. And this is like old curriculum. So it has like detailed like things you can find in like the old curriculum 2015's 283 page. So basically it include like in the CT3 level. We should able to take like comprehensive history examination of every child, and also know about the national guidelines for management of fever child, and also to identify some of the like causes like urinary tract infection, some meningitis or encephalitis. So this is our like HIEM 3 ARCP checklist. So I'm in the like the year 3. So basically it include in 18 like PAP 9 fever in all age groups. So we have to finish with whether by the teaching, some mini cakes or some CVDs. So I'll start with some quotation. So basically, fever is a nature's engine which she brings into the field to remove her enemy. Basically, it's sent by the Thomas Sydenham. So fever is not like disease. It is basically our like body immunity that's showing some sign and symptoms. So definition of fever. So they have like different definition, but basically fever is the most common, is a non-traumatic chief complaint of the pediatric patient presenting to the emergency department. So it include like 20 to 30% of pediatric emergency department attendance. And fever is defined as any elevation in body temperature above normal daily variation. So basically, a fever for the adult and fever for the children is like different things. We have to think about some variation as well. So 38 degrees Celsius or 101 Fahrenheit or above for under like 3 months, and for over 3 months of age of it will be like 39 or 102 Fahrenheit. It is basically like severe child, and typically the result of infection. So I basically got definition from Rosen's emergency medicine. So there is like different terminology for like definition of fever. So basically I've taken from here. And the causes of fever, basically as a doctor our mission will be to find out the source of the fever. So it may be meningitis or encephalitis, and some respiratory infection like pneumonia, kidney infection or urinary tract infection, some arthritis, Kawasaki disease, and flu like viral influenza, ear infection, Rogelia or viral cause of fever with a rash, tonsillitis, common childhood illnesses such as chickenpox and whooping cough. Also after the vaccination for the like pediatric groups, overheat like too much bedding or clothing. So these are the like basically the causes of like fever. But as any doctor we have to like see the The dangerous causes in the above, like meningitis, encephalitis, respiratory tract infections, some UTI, some Kawasaki diseases. And also, like regarding like etiologically, like a bacterial, viral, and other cause, divided into like different age group, like 0 to 28, 1 to 3 months, 3 to 36 months, and 3 to adulthood. It basically help to like treat with some antibiotic, but for any doctor will basically treat with the empirical therapy. So it is not that much important for as any doctor, so I'll not go through all the details. So approach, approach will be like history taking, examination, investigation, and the treatment. So can anyone tell me about like how to like take a history for a feverish child? Anyone volunteers?
Duration of fever.
Duration of fever, yeah.
Duration, onset, character,
Onset, character. So
maximum
basically,
temperature. Yeah.
yeah, maximum
Asso-
temperature recorded,
Associated symptoms,
associated symptoms,
Yeah.
uh,
Relieving
travel
factors.
history.
Rashes.
rashes. Very good, Saurav.
Mm.
Because rashes are very important in the like pediatrics age groups. So basically, I've divided as like
think,
the
yeah, I
basic
think,
thing.
yeah, Sundar, sorry. Now, I mean, the history pattern has to be the same, but few difference.
Yeah,
I mean, in temperature and high temperature fever, I think in any history, you must ask the travel abroad in the UK because a lot of people go on holidays, any contact with infectious diseases, in kiddies, especially whether they have been immunized against the contagious diseases or not.
contagious disease. Yeah,
And similarly, sometimes you ask, oh, has your child have been immunized recently? So there are a little bit few questions you have to ask differently in kiddies, relevant to their age. So otherwise you're absolutely right. The history are the same, but a couple of few questions, just brainstorming. So what's the difference between kiddies and the adult?
yeah. So basically, for like history taking, it is bit difficult in the like pediatric age group, because the pediatric we cannot get like direct history, so we have to like get a like collateral history from the parents carer. So basically, we have to find out like whether the fever, onset, duration, any recorded temperature at home, associated like febrile symptoms, any antipyretic use or response. Also, we have to ask about any antibiotic use, because that will like change all the symptom and sign, and any focal infective symptoms, any history of rashes, which is very important in the like pediatric age group. Also, we have to take account in the oral intake and urinary output, whether there is any sign of like dehydration. And also Mr. J also says the vaccine history, also for like birth history if less than 3 months, so we have to like take birth history as well, and any like past medical history, and recent travel abroad or contact with any traveler, contact with the unusual individual, and GI offset. So we have to like take account all the things uh, in the history part. And also during like a COVID pandemic, and so we have to take the detail. But for me, like this is like a general like fever history taking. And basically it should be focused in the length of illness, presence of any localized symptoms, and any persistence past medical history. If like less than 28 days of infant, like birth history, any presence of maternal infection like HSP or any group B streptococcus. Also the immunization status, like sick contact and use of antipyretic, and prior use of any antibiotics. So it will change like any sign and symptoms. Also an cough and congestion, like it suggests like pneumonia or viral upper respiratory infection, or harsh or barking, any seal like a cough, suggests like croup, or any viral laryngotracheal bronchitis. Also vomiting and the diarrhea related to the gastroenteritis, or the presence of maybe sore throat or lymphadenopathy with the viral streptococcal pharyngitis. So it may presented with any vomiting and a diarrhea. Also like we have to take account in the oral intake, because in the like pediatric group blood volume will be very less than the adult, so they are easy target for like some dehydration. And also any history of any lethargy, irritability, altered mental status, and severe dehydration. These are like danger signs for like for meningitis and encephalitis, which we have to think. And for rashes like rosella, a life-threatening condition like a meningococci with a rash, Rocky Mountain spotted fever, and toxic sick syndrome. These include the rashes. Headache and neck pain, like same like a meningitis and encephalitis. Some ear pain related with the like otitis media or ear infection. So on the physical examination,
I think Sundar, sorry, I just want to interject here. When we take the history, because sometimes we see that the people are bugged with the history with the patient. They keep on asking a repeated question to a deaf old, Alzheimer's patient. Now, when you take history, so the history has different components. For instance, one component of the history is to confirm the diagnosis, so whether this diagnosis is right, which doctor is suspecting in his head. And the second component of the history is so to know the degree of illness, so how unwell people are with this problem. Okay, so that's also few questions about that history. And similarly, as I remember from the oral intake, now, some question you ask when there's some sign there under the physical examination, because when you see patient in practice, history examination are going side by side. They are not a linear fashion. They are going parallel. So there you can ask mom, oh, how many nappy, wet nappy or how oral? Because otherwise, if you tell the mom will say, no, oh, my child has not eaten anything, you see what I mean? So the history has a components. So as to always make your mind, divide your mind into components. Like this is the component which confirm the diagnosis. This component assess the severity of the illness. This component is the treatment, and this component is how I will monitor these patients. So history had different components, though it's not in the books, but practically that's how we do. If you think now, while taking history, you will understand what I'm talking about. Okay, guys, thanks very much.
okay, thank you, Mr. J. So basically, this is like history and examination and like treatment is goes side by side for like especially in the pediatric age groups. So it is not like different, like you take history, you do physical examination and go to like treatment. Sometimes like for like if we find any red sign, we have to directly go for like treatment, and later we take like a history and get examination. So for like pediatric age group, there is like the mnemonics, it is for like 3E. So 3 basically says the ENT and exposure and extremities. It is basically for the physical examination of pediatric age group. So we go with the like ABCD approach. So assess ABC to identify any and like treat any life-threatening problem. So in order to maintain like vital function before disease, and we have to like give specific therapies are started. So before we go like for like specific therapy, sometimes we have to, if we found like ABCD, then we treat A, and after that we'll treat B, after that we'll treat C, and go side by side. And also the important thing, when to involve like senior ED staff, PICU and senior pediatric staff in the child. Basically, if you think like the child is very critically unwell, then we have to like involve like senior staff in the early phase. And also like measure record temperature, for like measuring temperature for like a pediatric age groups. We can use like electric thermometer in the axilla if it is less than 4 weeks of age. And for the older, like electronic or the infrared tympanic thermometer can be used. But for like less than 4 weeks of age, it is not like reliable to use like tympanic thermometer, which we basically use in the department. So for less than 4, it is better to go with the electronic thermometer. And specifically like short for like impaired any consciousness level, lack of recognition to the parents and carer. We have to like red flag those things. And for every like 6 children, we have to like measure the like blood glucose level, because for like children we don't go like routine blood every time, so we can get like blood glucose level easily. Next is the like early recognition and treatment for like respiratory failure, any shock, to avoid like deterioration and subsequent cardiorespiratory arrest. So basically in a pediatric age group, they may have like a respiratory component more than the cardiovascular. So we have to like for more focus on the respiratory cause, and administer oxygen if like SpO2 is less than 94 to maintain oxygen saturation more than 94%. And for any like shock pediatric, we can give like normal bolus saline of normal saline 0.95% with a like 20 ml per kg. It is basically IV or IO route. So sometime in the pediatric it is very difficult to get like IV cannulation, so intraosseous route may be the helpful line for like pediatric age group. And like sign of like shock, if there is any tachycardia and capillary refill time is more than 2 seconds, motile skin, purpuric rash, and decreased conscious level, these are the sign of shocks. Then this time we have to like start like early fluid therapy. And also in case of like a suspicious of meningococcal disease, we have to give like IUV or IO, like benzyl penicillin or cefotaxime as soon as possible. So these are some like history part, examination, and finally like the treatment part. So it goes side by side in the pediatric age groups. So the only question we have to face from like pediatric side, from the parents or a carer, like, doctor, may my child needs a blood test? So the answer is very difficult to like provide to every like parents. So we have to be very cautious to answer whether is it a yes, no. It is not like straightforward question. So basically for pediatric, mostly the fever is from the mostly the viral thing. So most of the time we don't need any like routine blood test. So basically we can do like a blood BM. So we can see whether a child is eating and drinking well or not. So only if the like you think like infant is unwell and it is under 3 months, then like a blood test is required. Or any suspicious of any meningococcal infection or meningitis, or any suspected pyrexia of unknown origin, or the over 3 month and one or more like one or more amber or red feature of from the traffic light table, then we need like blood test. So blood test basically include for a child is like full blood count, CRP, blood culture, and the lactate level. So we know when we follow the like sepsis guideline for pediatric, these are the like routine blood tests. But for the adult, we also had ANE and the LFTs. But for children, the ANE and LFTs only when like kidney, liver is suspected the source of fever. So the question will arise when we have to do like a lumbar puncture. So it is very like painful to be a like a parent if their like child need like LP, because it is very painful, and they don't want like LP or any blood test. So we should be very conscious about those things. So when like LP is indication, so if any unwell child like less than 1 month old, then LP is indicated, and before starting any antibiotics, or any less than 3 month unwell, or any WBC is 5 or more than 15 10 9 per liter, then that time we have to like in the mind for the alpha indication before we starting the like antibiotics. Also like like less than 3 months, basically like I have already said, we can do like full blood count, blood culture, CRP, some urine or the lactate. And also if we think of any listeria infection, we have to add like ampicillin for like coverage of listeria. And for the more than 3 months, like full blood count, blood culture, CRP, and the urine. These are the like routine tests if we need it. And for the X-ray, if like temperature is more than 39 and W cell count is more than 20 or clinically unwell, then only the chest X-ray is routine. So it is like different for like adult and the like pediatrics. In adult, we go for like a routine blood test, X-ray, all those things. But for pediatric, we have to think multiple time whether we have to do like blood test, we have to do lumbar puncture, or we have to like chest X-ray. So these references I found from like Oxford Handbook of Emergency Medicine. So finally, like the treatment part. So basically, if we follow the nice guideline, there are like different things for like treatment. So for the fever, we basically give antipyretic therapy. But before giving like antipyretic therapy, we have to be cautious about like effect of body temperature reduction. So one of my colleague has already presented an febrile convulsion. So like antipyretic doesn't prevent any febrile convulsion, so should not be used specifically for this purpose. Also like physical intervention to reduce body temperature and drug consideration, and finally the advice for home care. So if you go through like a nice guideline, you can follow this one like antipyretic intervention. So we'll go detail on my next slide. But before giving to the any like antipyretic therapy, we have to be very cautious about all those things and advice for home care. So for like any antipyretic intervention, basically consider using either paracetamol or ibuprofen in the children with the fever who appear distressed. So we don't give everybody with the fever for like paracetamol or ibuprofen, but only when the child is like appear distressed, or like parents are a bit concerned, they don't think the child is well, then we have to like be we can give some antipyretic intervention. So if you go through like BNF, basically the paracetamol dose like orally. So these are the doses. You can go through the BNF. So I've basically got it from like BNF. It just shows like with the age group, we can like give like the doses like for like 3 to 5 months. We basically give 60 milligram every 4 to 6 hour. Maximum dose is like 4 dose. So for pediatric, it is a bit difficult to calculate the doses. So we have to like use the BNF, and so according to BNF, we can give the doses. Next is like tepid sponging is not recommended for the treatment of fever, and should not be like underdressed or overwrapped for like fever. And antibiotic agent don't prevent any febrile convulsion, and continue only as long as child appears distressed. And advice for home care, like detect any sign of dehydration, identify a non-blanching grass, keep their child away from nursery or school, and to notify the school or any nursery. So basically, before giving like if we are thinking patient is well and we can discharge home, so we have to give a like clear instructions to their parents regarding like any sign of dehydration or any like non-blanching rashes, and to notify the diseases. So these are the things we should take in mind before discharging home. So so this is like traffic light like signal. So anyone know about like this traffic lights in pediatric age group? So this traffic light is like green, amber, and the red light. So we should know about this thing before like uh, we know about like any febrile child. So it include like color, activity, or respiratory, circulation, hydration, and other things. So for like amber and red reason, if it is more than one or two, then sometimes we have to like do like blood test, inform to like pediatrics teams. So if you go through like a nice guideline or Oxford Handbook of Emergency Medicine, you can get this table. So we should know about like this, like traffic light, green, amber, and red. And next will be like if the diagnosis is reached, then we can like give the like treatment accordingly. But if the diagnosis is not there, then traffic light system can be used, because every time we cannot like find any focus of the fever, then we have to be like more conscious about any history and traffic, any examination part to find out whether there is any red light, feature are present or not. But if like child has any red feature basically in the traffic light, then we have to like refer to for the admission. If the in the amber region, like consider like discharge with a safety net plan, verbal or written advice can be given. For every green pediatric age group, then we aim to discharge with the advice sheet and adopt like low threshold for admitting febrile infant is less than 3 months. For less than 3 months, then we have to like follow the low threshold level. And if we bit confused whether to discharge home or to admit, then we can observe for a period, and it will help to like reassurance the parents and also for us like A&E staff. And considering the discharge, like take into account like family and social factor, as well as like parental wishes and consent. So it is a bit different from like adult age group. So whether we have to discharge or admit the patient, so we have to like consider different things in a mind, like so these are like some strategies for management of febrile child younger than like 3 months. So we have like different studies. It is like study based on like Philadelphia, Rochester, and Boston. So these like 3 studies has been done. So it include like age, temperature, examination, and laboratory values, high risks and low risks, and performance. So these are different strategies that is used whether to treat or treat like febrile infant younger than 3 months. So these are the like some of the studies that happen. So you can go through this. I have got it from like Rosen's emergency medicine. So these are like some of the like disease focus. So I cannot cover like all the disease progression. So some of the like sign and symptoms that will help if some pediatric age group came with like fever. So first will be meningococcal disease. Can anyone like say like symptom and sign of any meningococcal disease age? What will find in like sign and symptom? Anyone volunteers?
Non-blanching rash,
Thank you, Dai.
Vomiting.
kind of stupor. Probably child is like listless most of the time.
Thank
Fever,
you.
cough.
Fever, cough. Okay, basically, so I have just highlighted some of the things. So non-blanching rash, particularly with one or more of the flowing, like ill-looking child, lesion larger than 2 mm in diameter, porphyria, capillary refill time more than 3 seconds, and neck stiffness. These are some important things we have to consider.
I think, yeah, Sundar, you're very good. But the classic meningitis symptoms are not percentage-wise less than the non-specific sort of meningitic sort of symptom in kiddies, especially in young children. Palpate the fontanelle, and if the extremities are cold in unwell child with high temperature. So again, this is not pathognomic. This is very common in children who are unwell with meningococcal septicemia. Fontanelle and the cold extremities in an unwell kid with high temperature. So I think also bear this thing in the mind as well.
Thank you, Mr. J. So we'll go to, we have like bacterial meningitis, herpes simplex encephalitis. You can go through the nice guideline, like this is like, you can get like fever management under 5 age groups. So you can go through the like this table. And another is like pneumonia, some urinary tract infection, septic arthritis, and Kawasaki disease. So you can go through the table. So can anyone know about Kawasaki disease? Any sign and symptoms? Any volunteers?
Fever not relieving for more than 5 days.
More than 5 days?
Oromucocutaneous syndrome, we call it. So oral ulcerations, conjunctivitis, and basically some difficulty in passing urine and eye redness as well. And the lymph nodes, cervical lymph nodes, palpable.
Strawberry tongue as well.
Strawberry tongue. So basically in the NICE guideline, it is just included like fever for 5 days or longer and may have some of the following like bilateral conjunctival injection without exudate, erythema and cracking lips, strawberry tongue, as Rosina has said, or erythema or oral and pharyngeal mucosa, edema and the erythema in the hands and feet, polymorphous rash, and cervical lymphadenopathy. So if we found, then we have to like think about whether it's a Kawasaki disease. So these are some of the like focal causes. So we can like treat according to sign and symptom. So final things, if like some children came with like a fever, then we have to think whether it is sepsis or not. So these are the like our DBTS trust protocol. So we have like 3 sepsis flow chart. So it is for like under 5, it's 5 to 11, and another is 12 to 17. So you can go through this chart. We have like you can find it in the MyED flow chart for sepsis children in the DBTS. So basically the difference here is if you go under 5 years, like sepsis is a time critical condition, screening, early intervention, and immediate treatment save lives. This tool should be applied to all children under 5 years with suspected infection or who have observation outside normal limits. So for the lower threshold of suspicion for age less than 3 months and chronic diseases, recent surgeries, immunocompromised, or communication difficulties. So in those conditions, we have to like put a lower threshold. So if you go through the chart, like has a POWS triggered. So can anyone know the POWS? Because in our, yeah.
PAW, pediatric warning score.
Yeah, it's a pediatric warning score. In our department, we use like a POP score. So if like has a like a POS trigger or any child with a fever or looking sick, so or any parent and the carer very worried. So these are the things we have to like think every like feverish child. We have to think first whether it's a sepsis or no sepsis. So if you go through all the things, basically definition wise here is like the difference is like tachypnea and the tachycardia definition. So it has been like less than 1 year, 1 to 2 year, and 3 to 4 year. So we can use this chart for like under 5. Other than that, if you go through everything, so like it is like same. And finally, if we think like red flag sepsis, then we have to follow the pediatric sepsis 6. Like it should be within like 60 minutes or as soon as possible. So if you go through like 5 to 11, the thing is same, but only the like tachypnea and tachycardias, the severe, moderate, the rate number will be different. And the only thing like a red flag sepsis, then we have to like activate like pediatric sepsis 6, and it should be activated as soon as possible or always within like 60 minutes. And for like 12 to 17 years, like they have defined severe tachypnea and tachycardia of more than 25 and tachycardia of more than 130. And other things, it is looks same like POA activities, feverish child looking sick, parent or care very concerned, then we should follow this chart. If we found like so these are the three charts for the sepsis screening. For but adult, it is like one single chart. But for pediatric, the only difference is like we have to know the values, and we should follow this sepsis toolkit. So it is very easier to follow, like under 5, 5 to 11, and 12 to 17. So we discuss about like sepsis at the last. So can anyone know what is like pediatric sepsis 6? Any volunteers? If we don't know like any sepsis, then we don't think about like how
Come
to
on,
like
guys.
treat that thing. So
Come on, guys. Very easy question. Sundar asking very easy question.
so because we know it is like sepsis, so we have to treat, because the sepsis is very like a life-threatening condition. So we should know about like sepsis 6. So there is an adult sepsis 6 and it is like pediatric sepsis 6. So can anyone volunteers can say like pediatric sepsis 6? What is sepsis 6 in pediatrics? Any
Come on,
volunteers?
guys. You have to diagnose. You have to do blood. You have to put antibiotic. Come on.
It is already written here, but
Yeah,
some
yeah.
of the thing, yeah, we have to know. So
It's a give 3, take 3. So take 3 is kind of blood IV access, blood culture, and
blood culture.
give 3. Third one is
So there is a
and-
difference between adult sepsis 6 and the pediatric. That's why I'm focusing.
You know the
If
light
anyone
type
know,
as
yeah.
well.
so give 3 would be probably the same: oxygen, IV fluids, and antibiotics.
So here is like pediatric sepsis 6. So it should be completed within 1 hour. So the different here, we have to find it out, like consider for inotropic support early. So give high oxygen, flow oxygen if clinically indicated, more than 94% of saturation to obtain, and obtain intravenous or intraosseous access, because it is like intraosseous IO as well in the like pediatric. Give antibiotic both an IV or IO. The difference is the IO here in the like pediatric. Consider fluid resuscitation, involve senior clinician specialist early, and consider for inotropic support. So these are the pediatric sepsis 6. So it is different from the adult. So we should know about these things. If we suspect like that pediatric sepsis, then this is the things we have to finish within like 60 minutes or as soon as possible. So can anyone tell me then about like adult sepsis 6? Any volunteers? So we can like differentiate whether it is the same or different. Adult sepsis 6. Any volunteers? Come on, guys.
IV fluids.
They
Are
should
you
work
good?
more often in resource.
3 ins and 3 outs.
3 ins, 3
ins
outs,
will
yeah.
be, oxygen, antibiotic, and fluids, and then 3 out should be the lactate, urine output, and
Blood cultures.
yeah, blood culture. Thank you,
Okay.
Dr. J.
These things should be in the tip of tongue. So thank you, Cecile, for like highlighting like sepsis 6 in the adult.
More work and resource. More
Yeah.
work and resource.
But basically the adult sepsis 6 is a 3 in 3 out. So administration oxygen, take blood culture, give IV antibiotics, give IV fluid, check serial lactate, and measure the urine output. Though these are the adult sepsis 6. So this is the pediatric sepsis 6, which is quite different than the adult sepsis 6. So I have to think about these things. And finally, these are my references and my take-home messages. So for like a sick febrile child, the source is the key. If you find the source, further investigation may not be necessary. and look for any sign of serious illness and suspect the scary stuff in all children, like any like red or amber sign. Investigate as indicated, not as a routine. So we don't go for routine blood test in the pediatric age group, only indicated whether it is needed. Antibiotic are not always the answer for like febrile child. In the febrile child, if any doubt, then a longer period of observation and senior opinion never go amiss. So these are my take home messages. So thank you everyone for my presentation. And
Yeah, well done, Sundar. I think that this is a very wide topic because there are so many conditions which lead to temperature to the kiddies. And I absolutely agree with you, 100% take home message. I think so much so that the younger children, we need to be really careful when we discharge home. Hence, a consultant sign of fever under in infants. Uh, I mean, the other indications are like investigation, as Sundar has mentioned. I mean, if the child is unwell, then you start thinking of the other stuff. If the red flag signs are there, and the little bit difference between virus and the bacterial infection, because with the viral infection, kiddies will look miserable. They won't look that unwell, that like that motor set of that really bad set of stuff come in your head. So, but if I think we are not sure, please do seek help in infants. Very important because the mortality is very high in infants with septicemia.
so any more question? Or we can discuss as well.